Okay, thanks. And Julie has asked, do you always use this technology for musculoskeletal pain / injuries?
We use this technology for every patient we see as their first appointment. We use this technology for reviews, and where we think it's going to be worthwhile, we use it for diagnosis and treatment. So if a person comes in with a corn under the second MTP joint, we will take a baseline gait of their walking, and if it's been there for a long time, we'll then educate them and say, we would like you to come for a 30-minute gait analysis, and what we'll do is we'll use metatarsal pads or taping or a combination to try and redistribute the pressure away from that high pressure site causing the corn, and then discuss where we go from there, whether it's orthotics, whether it's padding, whether it's rocker shoes, whatever, to try and resolve the problem rather than just maintaining it.
And on that note, do you find, using the example of the corn under the second met head, do you find that there is one or two interventions that are generally more successful than others, or is it a real lottery in terms of what works and what doesn't?
No, I think it's not quite as much as a lottery. It's understanding why it's there. So if the first metatarsal is dorsiflexed, it's there because the first MTP joint is not weight bearing. If it's there because of there's a scar tissue there, we need to address the scar tissue with a silicone pad. If it's there because the metatarsal is dropped down or there's a short first metatarsal, we need to offload it. If it's there because there is some dysfunction through the midfoot joint complex or the rear foot joint complex, and the joints are really stiff and the tissues, the soft tissues are very contracted, we need to address the soft tissue contraction and the stiffened joints. So soft tissue work, joint mobilization, direct dressings, footwear modifications or selection, for example, a shoe with a high toe spring, like a runner, for example, or orthotics would make up the solution. But the question is, how do we know which one? Well, we can tape the foot to bring the first metatarsal down, if it's possible, to get weight bearing and see if that transfers and how much it transfers. We could put a felt pad on the heel and see how much weight that transfers back into the heel. We could put a metatarsal pad and see how much offloading that is on the site, and so on. And so plantar pressure really provides an understanding of, okay, well, if I do this, how's that going to affect the foot and what's the outcome I can expect?
Yeah, it's a great application because I'm sure I'm not alone in this. When someone has that corn on the second met head, I might do a met dome, for example, and send them on their way. And it's probably not until you review them, say 4 to 6 weeks later, that you get any idea of how effective that treatment's been. And so then if it hasn't worked, you try something else, maybe a rocker sole or whatever it might be. So to be able to use 3 or 4 interventions and analyse the outcome immediately with the plantar pressure is a great way of knowing that you're on the right track, which I guess gets back to that point you made earlier about having confidence that you know what's going on.
Okay, let's move on. Cleaning the data. We need to first make sure that we get the right footprints. So if we've got a wheelie walker, we've removed the tracks, or if it is a walking stick, we've removed the point of the walking stick. So we've got the right footprints, and then we start looking at selecting them. We take away the partial ones, we take the ones that are skewed, the ones that are not correct. So on the left-hand side, you'll see a little group of footprints. The third one on the right-hand side, where the footprint is sort of skewed, we've removed that from our data set. We look at angles, we look at weight bearing of the weight, the pressure mapping. We look at the shape of the foot, of how much the foot is weight bearing, the surface contact, and we come out with a average footprint that we can rely on. We then look at the analysis side of things, the data acquisition analysis part 2, and that is looking at the pressure mapping. Most commonly, we'll see the pressure mapping that is average, which we'll see in the footprints on the left, but we can also see the maximum pressure views, which are the ones in the center, and the integral pressure views, which is the ones on the right. These are the same footprints, but if you look at each one, the distribution of colors are slightly different. So if we look at the maximum pressure, it focuses on the areas of the foot that receive the peak pressure loading that may well overload tissues. So we might have an example where a person has got such levels of overloading, but the body is just able to compensate that enough so they don't have any substantial symptoms. You know, the patients who say, oh, look, my feet are a bit achy at the end of the night, or they're a bit sore after exercise, but I don't worry about that. You get that when you're 40, that sort of thing. But that same person, if they go on an overseas holiday with hours and hours of walking, particularly up and down stairs, those forces grow to a point where the tissues get strained and they become injured. So the maximum pressure view gives us key data of the level of risk they are for future injuries. The integral pressure is a really key one too, because it looks at how long the pressure is focused in a particular area. So the key thing here is the time of the pressure. So maximum pressures may be tolerated by the body if the tissues are loaded for a very short time. However, if the loading is applied to a tissue for a very long time, particularly in a high-risk foot, then it can actually cause the tissues to not have enough oxygen, lead to necrosis and ulceration, which is often seen in the case of diabetic ulcers. So these three ways of looking at the pressure mapping, the colour palette of where the pressures are really, really important. The other thing that's really important is the centre of pressure, which is the white line up the middle of the foot, and the graphs in the centre, which are called pressure versus time curves. As I said before, the centre of pressure is a combined average of the body weight and from gravity and the ground reaction force through the foot. And this tells us where the trajectory or the pathway of the force goes through the foot. But the shape and the fluidity of the trajectory, through that we can understand muscle and joint dysfunction. Now, the centre curves, I've referred to them as pressure versus time graphs. You might have heard them as called force versus time graphs. That is a common name for them. But with pressure mats, we are only measuring vertical pressure, not horizontal pressure. To do that, you need a force plate. So pressure mats only measure the vertical pressure or the vertical force, which is called pressure. That's why we call it pressure versus time graphs. Now, this gives us a really key understanding of how much weight the rear foot is taking versus how much weight the forefoot is taking, and how fluid or smooth the graphs are, going up to a peak and then subsiding on the rear foot and forefoot. This gives us an understanding of the acceleration and deacceleration of the leg above and the foot itself. So there's lots of information we can see in this. We can see periods of hesitation where the foot doesn't move forward, but the weight significantly increases, or the weight doesn't change, but the foot continues to move forward. All of these things mean certain issues and factors that we can relate to certain conditions and why they're occurring. So once we've gone through the basics, then we start looking at what the data is telling us. So the data here, we can see that there's weight bearing forward on looking at the left foot. We can see that there's weight bearing in the talonavicular area distal to the heel. Now that's very unusual, but it's not unusual for medial ankle pain. We can see that there is the center of pressure comes fairly fluidly to the forefoot under the second and third MTP joints, and then has a substantial change of direction. We can see that the curves of the pressure versus time graphs are very, very flat, and the midfoot and the rear foot are loading substantially through the gait cycle, but so is the forefoot, which is almost for the entire stance phase. And we start saying, okay, that's not normal. It should be a double hump like we saw before. Why is that? What is that telling us? And what could we do about that? And if we worked out what we could do about that, if we then did some sort of treatment rationale and then walk the person over the mat again, could we see a change? So once we get to that point, we say, okay, what sort of tests could we use to give us the sort of reasons why what we're seeing is happening? So with medial ankle pain, we might think, okay, is there a medially deviated subtalar joint axis? So one of the tests that would be associated with medial ankle pain is this medial subtalar joint axis test.